on the YouTube channel, my YouTube channel. Um, let's talk today about a problem that is for sure so common that all of you, not once in life, but I could say once every day, are facing the problem of dilemma of polypharmacy in psychosis. Why this? Because I can remember so many cases where indeed patients were treated with more than two antipsychotics. This is unfortunately very common, and it is not so strongly supported by the evidence. I also remember many cases where the combination of antipsychotics caused problems, too much sedation, not sufficient efficacy. Some patients, I remember, they had four different antipsychotics at the same time. Not to mention the most dramatic experience that I had when I was very young of a patient that was coming out from a delirium after surgery, drug naive, not psychotic, just a delirium because of the age, about 70. And he was treated with heavy polypharmacotherapy and antipsychotics, and he died in the transport to another hospital. So these are dramatic events, unfortunate events, but probably can be done something to avoid and improve these things. What can be done? What can be done is to understand, is it good to combine two antipsychotics, three antipsychotics, or not? The question is not so simple to answer, and I will try to do my best during this presentation, also because we did some specific work in our group. The point is that antipsychotics indeed are used in so many different conditions that is quite common to have them in our everyday clinical practice. We use antipsychotics in schizophrenia and any kind of psychosis. Now we use a lot antipsychotics also in depression, of course in mania, increasingly in personality disorder like borderline, and of course in the later stages of dementia when there are behavioral and psychotic problems. So it means that the use of antipsychotics, now that we have the second generation's antipsychotic, is very wide and very common. And so this is why it's important to know how to use them. Good to combine or not good to combine. The question is even more complicated because each of the antipsychotics that we have, they have a specific indication from the old chlorpromazine that is indicated mainly in schizophrenia to other like haloperidol that has much larger indication also in agitation, in other kind of psychosis, but particularly to the new generation one, typical is example of quetiapine that is indicated for all phases of acute chronic maintenance of schizophrenia, acute depression, acute mania, and maintenance of bipolar disorder, and also as a potentiation for major depression. So this complex pattern of indications of all the antipsychotics that we have makes very difficult to choose if and when, how to combine them. Let's start from the guidelines. You know that we all have to adhere as much as possible to the guidelines. Psychiatry is an art, okay, but we have to follow the rules. And the guidelines are the one that gives us the rules. Also, when we have some legal problem, guidelines can protect us. And guidelines are very clear. Let's start from the Mosley, probably the most famous and detailed guidelines that we have. There are also others, of course. I like a lot these Mosley guidelines. They say something that is very clear and very simple. When there is a problem, you should choose the drug on the basis of the preference of the patient, the previous response, the profile of comorbidity, the profile of symptomatology. Then, if needed, you should increase the dose. If there is no response after 2 or 3 weeks, then you have to change the drug and follow the other pathways. Change, this is the word that is important. The guidelines suggest that when something is not working, you have to change it. Unfortunately, this is exactly the point where there is confusion, because many people, many of us, when they see no effect or few effect, they combine instead of changing. Is it correct or it is wrong? According to this guideline, it is wrong. If it doesn't work again, then you go to clozapine. Okay, these are the most, let's say, official guidelines that say a very simple and straight thing. Combination is something that should not be done. Also because we have so much heterogeneity in the compounds that we are using, aripiprazole, asenapine, lurazidone, and so on, that we really have a very flexible possibility to choose the best drug for each patient, avoiding combination. If you want a very strong antipsychotic effect, then you go on a strong D2 antagonist, 3 stars, risperidone, or asenapine, or haloperidol, of course, and then you reduce positive symptoms. If you want a mild effect, reducing the side effects, then aripiprazole that is a partial D2 antagonist, partial antagonist. Or you can go to the D3 modulators like asenapine that reduce again the side effects and also probably the negative symptoms. And then there are all the serotonergic receptors that are important. If your compound binds strongly to some, particularly the 2A serotonin receptor, it has a benefit in side effects or in other subforms, also an antidepressant effect. And finally, there are all the receptors that increase sedation and weight gain, like muscarinic and histaminergic. So from this pattern, we already have a lot of possibility to choose the right one without doing combinations. And in fact, these are the 5 principles that I took from various sources that are the ones that are, I would say, written in stone, that are the ones that are most robust and strong about what we should do. First, what to do when we have to choose the antipsychotic. The target symptoms should be defined. What we want to do. Is the patient prevalent positive symptoms or with prevalent negative symptoms? And then we have to decide what we want to target first. If the compound has already worked for the patient in the past, of course, this is a very strong indication to use it again. Or I may add, if it has been useful in a family, father, mother, or brother of the patient. Otherwise, we choose on the basis of the adverse effect profile. This is also important because some patients may be overweight, and then we should try to avoid antipsychotics that give increased weight. Then we do the trial. If it is unsuccessful, a different antipsychotic can be used. If there is a severe negative initial reaction, of course, can be switched earlier. Of course, this is obvious. But again, the key word here is a different antipsychotic, not a combination. The fourth point is the most clear. The administering of more than one antipsychotic drug at that time is not suggested. So the majority of guidelines are very clear on the point that combination of 2 antipsychotics has a very poor support, despite the fact that it is very widely used. And the dose should be kept at the lowest possible effective amount for the patient, because The cumulative lifetime dose can lead to tardive dyskinesia, a lot of problems, so we have to stay low. So when we combine many antipsychotics, of course, we increase the lifetime dose for the patient, and so we can create a long-term damage to the patient. Therefore, coming back to the Mosley, the conclusion of the Mosley is that there is a lack of robust evidence supporting the efficacy of combined antipsychotic medications, except for clozapine, we will discuss later. I will not read the other points, but the conclusion is that there is no strong, but not even moderately strong evidence that the combination is right. However, other people has different opinions. In another recent paper from north of Europe, they start from a different point of view. They realize that indeed, whatever guidelines say all over the world, indeed, us, clinicians, psychiatrists, we prescribe 2 or 3 antipsychotics at the same time very frequently. We will see later the numbers, but I remember one survey in UK where more than 40% of the patients received at least 2 antipsychotics. So this is some kind of conundrum. All guidelines discourage you to prescribe 2 antipsychotics, 3 antipsychotics at the same time, but nevertheless, all the people does it. Why? And so this is a possible point of discussion. Antipsychotic polypharmacy is frequently used, although not recommended by the guidelines. But what is differing this article from the guidelines is that antipsychotic polypharmacy is effective and may be applicable in certain clinical situations where monotherapy with non-clozapine antipsychotics and clozapine has failed and clozapine is contraindicated. So this article is opening a window. It's not a complete no. There could be some clinical cases where combination of antipsychotics is not only possible, but is also better. The difficulty now is to understand when, in which cases. And therefore, they suggest some kind of algorithm were similar to the one of the Mosley, but differing on the fact that when you go to non-response and you have problems with clozapine, they suggest, okay, then you can go to non-clozapine antipsychotic polypharmacy. So we have some support from literature that the combination of antipsychotics, not including clozapine, that is a different discussion we will see later on, it is possible in some occasions, but which occasions exactly? This is something that I would like to go a little bit deeper later. Then there is also Gavin Reynolds that discusses the same issue from another perspective. Gavin Reynolds is very expert in pharmacology of antipsychotics. I know him since many years. He's just saying a very simple effect that we are talking about antipsychotic as a same class. But when we combine 2 antipsychotics of very different pharmacodynamic profile, they are not from the same class. So he says clinicians are facing an absurd regulation of the maximum dose to be prescribed. A practical example, if you have a patient that is taking 20 milligrams of olanzapine, in principle, we could not add anything because 20 milligrams of olanzapine is already 100%. So if we want to add 5 milligrams of aripiprazole, we are off-label because it's 20 maximum plus 5 aripiprazole converted into chlorpromazine or haloperidol, we are more than 100%. And this is a problem. And Gavin Reynolds say, we should not be so rigid, and we should distinguish the mechanism of action. If we are adding aripiprazole, just to follow the example, to olanzapine, we are not potentiating the effect on D2 receptor. We are modulating the effect on D2 receptor. So we are not giving a lot of treatment. We are giving probably less treatment compared to 20 of olanzapine alone. So, as you can understand, this creates quite a big complexity. Which combination is increasing the total amount of antipsychotics and which combination is not increasing? You should have a very complex algorithm that nobody that I know now already has produced. But the concept is useful to have in mind. Then some people is commenting the paper of Reynolds. There is discussion on these topics on the journals. And the commentary says, yes, you might also be right, but there is very poor evidence on what you say. Where is the evidence that the combination of different pharmacodynamic profiles gives a better outcome? Indeed, there is not much. And then you could go to the Cochrane Library. You know that the Cochrane Library is the Bible of knowledge because they do this very extensive meta-analysis where they include all available evidence and they follow very, very rigorous and straight methodologies to go to the best conclusion. Well, these authors focused on antipsychotic combination for schizophrenia and did a meta-analysis, very long meta-analysis, including a lot of studies, and they concluded that very low quality evidence is not supporting the combination of antipsychotics, not for efficacy, not for tolerability. And it's interesting that this topic came out again by the Finnish people another time, combining with a very nice research that was published on JAMA Psychiatry, combining aripiprazole and clozapine. I told you before that clozapine is different because clozapine combination is usually considered something that is allowed by guidelines because when you arrive to clozapine and you have no response, a combination is needed. And therefore, they focused on the specific combination of aripiprazole and clozapine, and indeed, it was better than clozapine alone and other combinations. And so they concluded that the current treatment guidelines should modify their categorical recommendation for discouraging all antipsychotics polypharmacy. So a very influential paper in a very influential journal is saying guidelines should change. We cannot tell people not to do what they are already doing. We have to educate people of what is best to do. So, a very small piece of information. Is it best probably to combine clozapine with aripiprazole in some specific cases? And let's see which other possible combinations. This is quite small maybe for you to see. It's just you can see in the paper is the list and the effect of all the possible combinations. So if clozapine and aripiprazole are indeed probably the best combination, there are many other combinations that have been used, some of which are less effective. For example, aripiprazole and risperidone combination, it looks probably not so effective. And this is quite logical. Aripiprazole, risperidone, mechanism of action is very similar except for the partial D2 modulation. So, and other combinations that you can see in the paper. Said that, there is this nice paper that in a very comprehensive way summarizes what is the situation of antipsychotic polypharmacy. He says the more the merrier. Is it better to combine more antipsychotics? And he's trying to understand which is the basis of the antipsychotic polypharmacy. First, it is much more common than expected. He cites 20-30%, but there are studies that the antipsychotic combination is also above 40 or 50%. And what, what is there in terms of evidence is not much. The best evidence is about, as we have seen, clozapine and some other compounds like partial agonists like clozapine and aripiprazole. But indeed, many other combinations are not supported, all the other possible combinations. And so it suggests that a slightly different algorithm for treating patients. Start with monotherapy, minimum 2 sequential treatment. Then, if ineffective, go to clozapine. If if clozapine is also ineffective, you can also make a combination of antipsychotic and clozapine without giving specific indication how to combine aripiprazole or cariprazine or what else. Because indeed the reasons for antipsychotic polypharmacy are very different. The people, when you ask people why you do an antipsychotic polypharmacy, some people answer you, well, because we want to reduce adverse effects, we want to access other receptors, we want to optimize D2 manipulation, we want to have a broader response in other symptoms, and we want to improve efficacy. So the ideas behind antipsychotic polypharmacy are very complex. But the exact answer could come from the pharmacodynamic. This is a very complex refiguration of the pharmacodynamics of the antipsychotics, but that could be useful for you and for us to understand when we have to do psychopharmacology with antipsychotics and which. Let's start from the first one. Clozapine and aripiprazole is indeed the combination that is most supported by literature and also by guidelines. Why? Because you see that clozapine and aripiprazole, they have a very complementary profile. We have clozapine that is not binding a lot on the D2, while aripiprazole is binding much more. You see, you can read this graph. The more you are close to the line, the higher is the binding. So on D2, aripiprazole is binding much more in a partial way, but much more. Same for D3. On the other hand, aripiprazole is much less on H1, so in terms of weight gain, and on H1, 1A and in 2C. So these two lines, the blue and the orange, create a new drug that is the combination of the two that has indeed the desired effects that we want to have, reducing the side effects of each of them. Some kind of artificial engineering combining two existing drugs. But not all combinations are so beneficial. For example, olanzapine and cariprazine are probably not as well useful as clozapine and aripiprazole because they are very similar in many of their actions. So I understand that this process is very difficult to do every day in our office before choosing a combination, but it's a useful exercise at least to identify 2 or 3 combinations and to look in literature how they are supported. This is why last year we published this paper because, as you know, many of the paper that I'm publishing, I'm working on, they come from the clinical experience. So we and my colleagues, we always had this problem. When we should combine the antipsychotics with different mechanisms of action, let's see if we can give at least a partial answer. And so we focused on a very common point that is, if you use a complete dopamine D2 blocker, like haloperidol, and you combine it with aripiprazole, that is a partial D2 blockade receptor D2 blocker, is it different? Is it useful? It is improving efficacy? Is it improving side effects? This was the basic idea. And indeed, we try to find what is there in literature, but not only in randomized clinical cases, also in randomized clinical trials, so clinical cases, open studies, just to have an idea, to combine all the evidence. And of course, according to the new nomenclature, it is useful to name the drugs about their effect, because the antipsychotics is a very old name, of course. And then in the article, we tried to go much in detail. It was difficult to do this table because a lot of these data are difficult to find in literature. That is the complete profile of all the antipsychotics that we have now. Complete profile means the binding. So, for example, haloperidol, you see, is not binding, not at all on the serotonin receptor, is binding very strongly on the dopamine D2 receptor, of course. And the other have different profiles. So this table is very useful because it's the basis for choosing which combination. From this table, you can draw the very nice lines that we have seen 2 slides before. It's the basis for that. And these are the cases that we found in literature. Not many, but very interesting because they all received a combination of complete D2 blockade with mainly haloperidol and partial D2 blockade, mainly aripiprazole, but not only. Some of them went well, some of them didn't go well. In the next slide, it's difficult to see, don't worry, you can read it in the paper. But I will summarize for you what's the message of this paper. Well, it was very interesting because the patients that went well, that showed improvement, they showed improvement not immediately. They showed improvement after 2 months, 3 months, many weeks. While the cases that show a worsening, the worsening was in the first couple of weeks, maximum 3. And the other point, that is not here, is in the text, is that the patient that had symptom improvement had a lower history of disease. So we created a theory about this. Combination of antipsychotics, yes or no? Our answer is that the combination of antipsychotic is possible in specific situations. For example, if you have a patient that is not drug naive, but with not a very long treatment, still the brain probably is sufficiently plastic that a partial dopamine D2 modulator can improve the benefit of a complete dopamine D2 modulator. If the length of the disease is too long, like 10 years, probably there are mechanisms there where this combination is not impacting sufficiently. And the second very important message is that you have to wait. You have to wait at least 2 months to see the benefit, because probably the adaptation mechanisms are quite slow in the brain. So what is the take-home message of our study that is giving for the first time an answer? Not for the first time, but with other people, but a very practical answer. If you have a patient with haloperidol that is not going completely well in terms of what? Negative symptoms or stability of the psychotic symptoms, you can add aripiprazole, for example. It would be better if the history of disease is not that long, but if you do it, you have to wait at least 3 months. And don't change it before, otherwise you don't see the benefit. Going to the end of the presentation, until now we focused on the combination of antipsychotics. And the main message that we have seen from literature and from our studies is that, in general, combination of antipsychotics should not be done, but in particular cases, like with clozapine, or with very different mechanism of action, like haloperidol or complete D2 blocker, and other compounds that have different mechanism of action, then there could be some benefit, even though not in all cases, and you have to wait sufficient amount of time to see the benefit. So this is the summary so far. But we have also the drugs. Consider that in psychiatry we have more than 110 drugs, not only antipsychotics. So what should we do with other polytherapies? Well, antidepressants. Antidepressants, if you are not so young, maybe you remember that in the 80s, the antidepressants were not suggested in schizophrenia. Everybody was telling, though, antidepressants in schizophrenia for sure will worsen the symptomatology because it will increase positive symptoms and so on. It is not the case. Many studies after that, now also in guidelines, we know that antidepressants, some antidepressants particularly like fluvoxamine or sertraline, have demonstrated relevant benefit without worsening of positive side effects, but with an improvement of negative side effects. This is a nice paper that you can study if you want to go deep on this topic, how we can treat negative symptoms in schizophrenia. So, okay, the polytherapy about antipsychotics, we discussed the one with antidepressants, but you can do many other things in terms of combination. First, we should never forget all the psychosocial interventions, rehabilitation, cognitive therapies, they are of course useful. Combination of antipsychotics we discussed. There are a lot of new compounds that modulate other systems that are under study or under early use to be considered, as well as the usual stabilizers that sometimes lamotrigine can give a little bit of benefit in terms of stability of mood and so on. And lastly, neurostimulation. You are probably aware that now we have the new techniques of transcranic magnetic stimulation that are much more effective than the ones in the past. And therefore, these kind of techniques can indeed be used also in schizophrenia for negative symptoms, and there are studies also for positive symptoms. So, we are in time for the conclusion. What we discussed today the very common problem of antipsychotic polytherapy that is oscillating between completely forbidden. Many guidelines, including the Maudsley, say you should never combine antipsychotics, to other people that suggest that some combination could be possible, and to the general population of us, psychiatrists, that are doing antipsychotic combination very frequently in clinical practice. I would like you to remember very few take-home messages. First, my opinion, but also the opinion of much of the recent literature, is that guidelines should be changed. There are specific cases where antipsychotic combination could be really better. It's important to be knowledgeable about which are those cases. The first and more clear is clozapine. Clozapine potentiation has been demonstrated to work when clozapine alone is failing, with aripiprazole, with risperidone, and so on. but also specific combinations of non-clozapine antipsychotics may work. Complete and partial dopamine D2 blockade. We saw in our study, but also in literature, that in some cases that maybe have a short history of disease, haloperidol-treated patients can improve with a combination of partial agonism with aripiprazole. And I'm sure that there are many other of these possible combinations to be studied. We need study to be thought about because we need to combine from a pharmacodynamic profile the available drugs. And the last point, combination can be done also with non-antipsychotics, mainly antidepressants, also mood stabilizer, and of course, all the non-pharmacological therapies like transcranial magnetic stimulation or all the psychosocial interventions. Thank you for your attention.